Welcome to our educational quiz video on pyrexia of unknown origin. Pyrexia of unknown origin is a syndrome that has long tested the skills of physicians to achieve a diagnosis in affected patients. It still remains a clinical challenge due to its wide differential diagnosis. In this video, we will discuss the causes, investigation, and management of pyrexia of unknown origin. So, let's begin.
Question 1. Which among the below is a part of the definition of fever of unknown origin? Option A, uncertain diagnosis despite 1 week of inpatient evaluation. Option B, fever more than 100° Fahrenheit on 2 occasions. Option C, fever more than 100° Fahrenheit on 3 occasions. Or Option D, no known immunocompromised state. Your time starts now. Time up. The correct answer is Option D, no known immunocompromised state. Nowadays, most patients with fever of unknown origin are hospitalized only if their clinical condition requires it, and not for diagnostic purposes alone. Thus the in-hospital evaluation requirement has been eliminated from the definition. Fever of unknown origin is now defined as follows. Number 1. Fever more than or equal to 38.3 degrees Celsius or more than or equal to 101° Fahrenheit, on at least 2 occasions. Number 2. Illness duration of more than or equal to 3 weeks. Number 3. No known immunocompromised state. Number 4. Diagnosis that remains uncertain after a thorough history taking, physical examination, and the obligatory investigations shown here. Question 2. Which among the below is the most common cause of fever of unknown origin? Option A, infections. Option B, malignancies. Option C, autoimmune conditions. Or Option D, drugs. Your time starts now. Time up. The correct answer is Option A, infections. The most common causes of pyrexia of unknown origin are infections. The most common infectious causes of pyrexia of unknown origin include tuberculosis, especially in extrapulmonary sites, abdominal or pelvic abscesses, subacute bacterial endocarditis, osteomyelitis, occult abscesses and infected implanted devices. Question 3. Which among the below statements about Morantic endocarditis is false? Option A. Morantic endocarditis patients have culture-negative endocarditis. Option B. Associated with difficult-to-culture bacteria such as Hossack organisms. Option C. Adenocarcinoma is associated with Morantic endocarditis. Or Option D. Associated with incidental finding of pulmonary embolism. Your time starts now. Time up. The correct answer is Option B, caused by difficult-to-culture bacteria such as Hossack organisms. Morantic endocarditis, also known as non-bacterial thrombotic endocarditis, NBTE, is a rare condition that refers to non-infectious lesions or vegetations on the endocardium. Morantic endocarditis occurs as a paraneoplastic phenomenon, especially with adenocarcinomas. Sterile endocarditis is also seen in systemic lupus erythematosus and antiphospholipid syndrome. Morantic endocarditis is highly likely in patients with incidental findings of a pulmonary embolism and high suspicion for an underlying malignant process. It is important to consider morantic endocarditis as part of the differential diagnosis when a patient with suspected malignancy presents with unexplained fever or other symptoms. Question 4. Which among the below is not a category of pyrexia of unknown origin as per Duroc and Street classification? Option A, classical pyrexia of unknown origin. Option B, nosocomial pyrexia of unknown origin. Option C, neutrophilic pyrexia of unknown origin. Or option D, HIV-related pyrexia of unknown origin. Your time starts now. Time up. The correct answer is option C, neutrophilic pyrexia of unknown origin. Duroc and Street classification of PO classifies pyrexia of unknown origin into 4 categories. They are, classical pyrexia of unknown origin, nosocomial pyrexia of unknown origin, neutropenic pyrexia of unknown origin and HIV-related pyrexia of unknown origin. Question 5. Which among the below statements is not accurate for a patient with fever and neutropenia? Option A, risk of infection is high in patients having neutrophil counts less than 500 per microliter. Option B, symptoms are more pronounced due to weakened first wall of defense. Option C, prompt initiation of high-dose, broad-spectrum antibiotics is required if there is hypotension. Or option D, if fever persists after 3-4 days of antibiotic therapy, antifungal therapy is added empirically. Your time starts now. Time up. The correct answer is option B, symptoms are more pronounced due to weakened first wall of defense. Neutropenic patients are at a higher risk of infections, however, their symptoms may be less pronounced due to the limited inflammatory response. Question 6. Which among the below statements about DRESS syndrome is false? Option A, expansion of the abbreviation is drug rash with eosinophilia and systemic symptoms. Option B, also known as drug-induced hypersensitivity syndrome. Option C, fever usually develops on the day of start of medicine and worsens with time. Or option D, beta-lactam antibiotics are a common cause. Your time starts now. Time up. The correct answer is option C, fever usually develops on the day of start of medicine and worsens with time. DRESS syndrome, also known as drug-induced hypersensitivity syndrome, is a severe and potentially life-threatening reaction to certain drugs. The condition is characterized by an extensive skin rash in association with visceral organ involvement, lymphadenopathy, eosinophilia, and atypical lymphocytosis. The onset of symptoms in DRESS syndrome is usually delayed, with symptoms appearing typically within 2 to 6 weeks after taking the medications. The treatment often involves ceasing suspect medications. Question 7. Which among the below is not a drawback of FDG PET computed tomography? Option A. Compared with gallium scintigraphy, FDG PET computed tomography offers images of lower resolution. Option B. FDG uptake by brain and kidneys may obscure pathologic foci in them. Option C. Patient preparation includes dietary precautions. Or Option D. Do not allow differentiation among infection, sterile inflammation, and malignancy. Your time starts now. Time up. The correct answer is Option A. Compared with conventional scintigraphy, FDG PET computed tomography offers images of lower resolution. FDG PET, fluorodeoxyglucose positron emission tomography, is a medical imaging technique that uses a radioactive substance called FDG, fluorodeoxyglucose, to detect metabolic activity in cells. FDG accumulates in tissues with a high rate of glycolysis, which occurs not only in malignant cells but also in activated leukocytes and thus permits the imaging of acute and chronic inflammatory processes. FDG uptake by brain, heart, bowel, kidneys, and bladder may obscure pathologic foci in them. Compared with conventional scintigraphy like gallium scintigraphy, FDG PET computed tomography offers the advantages of higher resolution, greater sensitivity in chronic low-grade infections, and a high degree of accuracy in the central skeleton. Question 8. Which among the below statements about familial Mediterranean fever is true? Option A. Familial Mediterranean fever is a common cause of fever of unknown origin in India. Option B. Colchicine is highly effective in treatment of fever seen in familial Mediterranean fever. Option C. Response to colchicine helps reliably diagnose familial Mediterranean fever. Or Option D. Within weeks to months of colchicine treatment, patients show remarkable improvements in the frequency and severity of febrile episodes. Your time starts now. Time up. The correct answer is Option D. Within weeks to months of colchicine treatment, patients show remarkable improvements in the frequency and severity of febrile episodes. Colchicine is highly effective in preventing attacks of familial Mediterranean fever but is not always effective once an attack is well underway. When familial Mediterranean fever is suspected, the response to colchicine is not a completely reliable diagnostic tool in the acute phase, but with colchicine treatment most patients show remarkable improvements in the frequency and severity of subsequent febrile episodes within weeks to months. Therefore, colchicine may be tried in patients with features compatible with familial Mediterranean fever, especially when these individuals are of Turkish, Armenian, Middle Eastern and North African Jewish, and Arab descent. Question 9, Case Scenario. A 65-year-old male was admitted to the hospital for a total hip replacement surgery. He has a history of hypertension and type 2 diabetes. During his hospital stay, he was treated with broad-spectrum antibiotics for a postoperative wound infection. On the 7th day of his hospital stay, he starts to complain of abdominal pain, diarrhea, and a low-grade fever. Patient was moderately dehydrated and blood pressure was recorded as 110 by 70 mm of mercury. Heart rate was 100 beats per minute, and respiratory rate was 18 breaths per minute. Temperature was 39 degrees Celsius. Laboratory results revealed white blood count of 12,000 per cubic millimeter and elevated CRP, which among the below is not an appropriate action in the management of the patient. Option A. Obtain a stool sample for Clostridium difficile toxin testing. Option B. Monitor vital signs and assess for signs of dehydration. Option C. Consider discontinuing the current antibiotic therapy. Or Option D. Use loperamide to avoid worsening of dehydration. Your time starts now. Time up. The correct answer is option D, use loperamide to avoid worsening of dehydration. Clostridium difficile colitis is caused by a disturbance of the normal bacterial flora of the colon, colonization by Clostridium difficile, and the release of toxins that cause mucosal inflammation and damage. Antibiotic therapy is the key factor that alters the colonic flora, and the most commonly implicated agents include the cephalosporins, especially second and third generation, the fluoroquinolones, ampicillin, amoxicillin, and clindamycin. The use of antimotility agents such as narcotics and loperamide in active Clostridium difficile infection is discouraged because use of these agents may result in more severe colitis. In this case, the patient's stool sample tested positive for Clostridium difficile toxin, confirming the diagnosis of Clostridium difficile colitis. The healthcare provider adjusted the antibiotic therapy, and the patient's symptoms improved over the following days and was discharged. Question 10, Case Scenario. A 35-year-old HIV-positive patient recently started on highly active antiretroviral therapy. Heart, is experiencing fever, weight loss, and worsening shortness of breath 4 weeks after treatment initiation. Prior to heart initiation, the patient had a low CD4 count and a high viral load, which improved significantly after starting therapy. What is the most likely diagnosis in this scenario? Option A, drug resistance. Option B, non-adherence to medication. Option C, immune reconstitution inflammatory syndrome. Or Option D, new opportunistic infection. Your time starts now. Time up. The correct answer is Option C, immune reconstitution inflammatory syndrome. Immune reconstitution inflammatory syndrome, IRIS, is a hyperinflammatory response that usually occurs within the first 6 months of initiating heart in HIV/AIDS patients. It is a potential complication of heart therapy and is characterized by a rapid improvement in CD4 count and a decrease in viral load after treatment initiation. The underlying mechanism of IRIS involves an imbalance between anti-inflammatory and pro-inflammatory cytokines that occurs rapidly after the recovery of immune function in HIV patients initiated on heart. In this case, the patient's symptoms, as well as the improvement in CD4 count and viral load following heart initiation, are consistent with the diagnostic criteria for IRIS. Question 11, Case Scenario, a 45-year-old female patient presents to your clinic with a history of fever of 39 degrees Celsius that has persisted for more than 3 weeks, confirmed by her medical records. She has undergone 3 outpatient visits, and the cause of her fever remains unknown, meeting the criteria for pyrexia of unknown origin. The patient reports experiencing recurrent headaches and weight loss of 7 kilograms in 1 month. She has no known immunocompromising conditions. Initial investigations, including blood tests, chest X-rays, and abdominal ultrasound, are performed, but no specific cause is identified. Tuberculin skin test yielded a negative result. Guided by potentially diagnostic clues, CSF examination was done. CSF analysis revealed a protein of 300 mg per deciliter, glucose concentration of 30 mg per deciliter, and cell count is 150 lymphocytes per microliter. What is the next appropriate action? Option A, conduct interferon gamma release assay as tuberculin skin test was negative. Option B, get HRCT thorax to identify occult branchial disease caused by Mycobacterium tuberculosis. Option C, conduct polymerase chain reaction test for Mycobacterium tuberculosis on the CSF. Or Option D, started anti-tuberculosis medications with adjunctive corticosteroid therapy to reduce CNS inflammation. Your time starts now. Time up. The correct answer is Option C, conduct polymerase chain reaction test for Mycobacterium tuberculosis on the CSF. A tuberculin skin test, TST, or IGRA, quantiferin test, is included in the obligatory investigations, but it may yield false negative results in patients with miliary tuberculosis, malnutrition, or immunosuppression, although the IGRA is less influenced by prior vaccination with BCG, or by infection with non-tuberculous mycobacteria. Its sensitivity is similar to that of the TST. A negative TST or IGRA therefore does not exclude a diagnosis of tuberculosis. Here, the patient reports experiencing persistent headaches, which raises suspicion for central nervous system involvement. CSF analysis reveals elevated protein levels, low glucose levels, and a predominance of lymphocytes, suggesting tuberculous meningitis. In this case, to confirm the diagnosis, a PCR test for Mycobacterium tuberculosis was conducted on the CSF sample, which came back positive. Consequently, the patient is diagnosed with extrapulmonary tuberculosis, specifically tuberculous meningitis, and treated with anti-tuberculosis medications and adjuvant corticosteroid therapy. Over the course of treatment, the patient's fever subsided, and her neurological symptoms improved. Question 12. Case Scenario, a 45-year-old man presents to the clinic with a fever of 102 degrees Fahrenheit, headache, joint pain, and myalgia that have persisted for 4 days. He reports a recent upper respiratory infection and was prescribed a 7-day course of amoxicillin by his primary care physician that was completed 10 days back. The patient has a history of hypertension and is currently taking lisinopril and hydrochlorothiazide. He has no known drug allergies. The emergency department physician suspected drug-induced fever and had decided to discontinue the patient's antihypertensive medications on the first day of fever. What is the next appropriate action? Option A, restart treatment with amoxicillin for the upper respiratory infection as it was inadequate. Option B, start treatment with erythromycin for the upper respiratory infection as treatment with amoxicillin was inadequate. Option C, continue antipyretic medications and monitor temperature for 3 more days as it is drug-induced fever. Or Option D, test for common viral infection like dengue. Your time starts now. Time up. The correct answer is option D, test for common viral infection like dengue. Inadequate treatment is less likely because the patient has already completed a 7-day course of amoxicillin, which should have been sufficient to treat a bacterial upper respiratory infection. As fever is persisting beyond 72 hours after discontinuation of the suspected drug, it is unlikely that this is drug-induced fever. Therefore, the most likely cause of the patient's persistent fever is viral infection, which can explain fever, headache, joint pain, and myalgia. Question 13, Case Scenario. A 45-year-old male, currently febrile for 2 days, presents to the hospital with a history of fever of 101 degrees Fahrenheit or higher, documented on several occasions over the past 3 weeks. Despite comprehensive history and physical examination, no clear cause of the fever was identified. The patient denies any recent travel, exposure to sick individuals or animals, and has no significant family history of cancers or inflammatory diseases. Extensive workup for infectious etiologies, malignancies, and non-infectious inflammatory diseases had not led to a definitive diagnosis. Repeat tests revealed elevated inflammatory markers, ESR and CRP. What is the next appropriate action? Option A, order an FDG PET scan with computed tomography. Option B, start empirical treatment with anti-tuberculosis medications. Option C, start empirical treatment with corticosteroids. Or option D, ask the patient to go back home and return when he has fever. Your time starts now. Time up. The correct answer is option A, order an FDG PET scan with computed tomography. In patients with recurrent fever, the diagnostic workup should consist of thorough history taking, physical examination, and obligatory tests. Patients should be asked to return during a febrile episode so that the history, physical examination, and laboratory tests can be repeated during a symptomatic phase. Further diagnostic tests should be performed only during a febrile episode or when inflammatory parameters are abnormal, because abnormalities may be absent between episodes. In this case scenario, considering the unresolved nature of the fever and elevated ESR and CRP levels, the physician decided to order an FDG PET scan with computed tomography. The images revealed increased uptake in the mediastinal lymph nodes, raising suspicion for a malignancy such as lymphoma, or an infectious process such as tuberculosis. Further diagnostic tests, including a lymph node biopsy, were ordered, which confirmed the diagnosis of lymphoma, and appropriate treatment was started. Question 14, Case Scenario. A 65-year-old diabetic female was admitted and treated for pyrexia of unknown origin in a hospital for a week. Patient was discharged as she was febrile for 2 consecutive days and no definitive diagnosis was made at the time of discharge despite extensive investigations. Patient has now come to you for regular follow-up and diabetic medications. You notice the patient carrying with her FDG PET scan report that revealed increased FDG uptake in the patient's bone marrow. What is the next appropriate action? Option A, order a repeat FDG PET scan with computed tomography. Option B, admit the patient and order bone marrow biopsy. Option C, admit the patient and strictly monitor body temperature. Or option D, ask the patient to return when she has fever. Your time starts now. correct answer is option D. Ask the patient to return when she has fever. In patients with fever, bone marrow uptake is frequently increased in a nonspecific way due to cytokine activation, which upregulates glucose transporters in bone marrow cells. Studies have shown that the percentage of undiagnosed PUOs at discharge varies widely, ranging from less than 10% to over 50%. In this case, the FDG PET may have falsely localized pathologic foci in the bone marrow. It is crucial for the clinician to consider the limitations of FDG PET and weigh the pros and cons of further invasive testing based on the clinical context and the patient's overall health status. Alternative diagnostic strategies or a watch-and-wait approach may be considered if the likelihood of a false positive result is high or if invasive testing poses significant risks to the patient. Question 15, Case Scenario. A 35-year-old female patient presents to her primary care physician with a complaint of persistent fever for the past 2 years. The patient reports that her fever is typically around 100°F in the evenings and 99°F in the early mornings, and there is documented reduction of body weight from 55 kg to 50 kg in the past 2 years. The patient has been admitted and evaluated multiple times by various healthcare providers, but no definitive cause for her fever has been identified. During the patient's visits to different healthcare providers, she has undergone numerous investigations, including blood tests, imaging studies, and even a lumbar puncture. All results have come back normal or inconclusive. Despite this, the patient insists that her fever is genuine and is causing her significant distress. When you examine her, you find a 1 cm cervical lymph node in the right mandibular region, and oral examination revealed poor oral hygiene and tobacco stains. What is the next appropriate step for the management of fever in the patient? Option A, refer to a dentist to drain a hidden dental abscess. Option B, refer to a surgeon for lymph node biopsy. Option C, refer to a psychiatrist for managing her stress. Or option D, admit the patient for further testing. Your time starts now. Time up. The correct answer is option C, refer to a psychiatrist for managing her stress. The patient's medical history reveals multiple hospitalizations and medical evaluations for various ailments over the past few years, with no clear etiology identified in each case. In patients with recurrent fever lasting more than 2 years, it is very unlikely that the fever is caused by infection or malignancy. In this case scenario presents a patient with a persistent fever for 2 years, with no identifiable medical cause. The patient's history and presentation suggest the possibility of factitious disorder. The physician should approach the situation with empathy and recommend a referral to a mental health professional to address the underlying psychological issues.
Thank you for watching our educational quiz video on pyrexia of unknown origin, PUO. We hope that this video has helped you understand the challenges of diagnosing and managing PUO, as well as the importance of early recognition and appropriate investigation for timely diagnosis and management of underlying conditions. Thank you again for watching, and we hope to see you in our future educational videos.